course, yeah. So Harvey Smith is presenting for Bradley Weiner. He holds a Bachelor of Arts in Chemistry and Physics from Harvard University and an MD from Penn State College of Medicine. He did his residency at Thomas Jefferson University in Philadelphia at the Department of Orthopedic Surgery. He did his fellowship in collaboration at the Rothman Institute. Dick Rothman lived across the street from us in Philadelphia, and he's received many awards and has published a great deal. He's an assistant professor at the Weill Cornell Medical School and the Methodist Hospital Research Institute in Houston. He will talk to us today on nanoporous silicon particles as a delivery system for the treatment of musculoskeletal disease. Dr. Smith.
Thank you, and thank you for the opportunity to speak. And normally I'm used to speaking at a medical conferences, so it's a little bit intimidating to be in this room after hearing all of you speak, but I'll do my best. There we go. So this talk's going to be on, we have collaborators at University of Texas, you heard from Ennio earlier, and we've been collaborating with them, working on translational aspects of their technology to diseases. So I look at things from a little bit of a different perspective, from the opposite end of the spectrum, thinking what do they have and how can we use it for some of our clinical problems. So a lot of my talk's going to be a little bit of a step back and explaining what situations we're dealing with, and then I'm open to any suggestions anyone has for ideas for how we could possibly translate some of all the wonderful ideas I've heard here to perhaps address some of these diseases in ways we haven't thought of yet. Myself, I'm an orthopedic surgeon. I do spine surgery, and then I also do a lot of laboratory research at the hospital. So my life spent sort of in two places. 2 days a week I'm in the laboratory doing tissue culture work, and the rest of the time I'm either in clinic or in the operating room. And basically, most of what I do is dealing with end-stage, I guess what we call phenotypes here, the end-stage results of degenerative diseases of the spine, be it the joint in the knees, the hips, or the spinal column, or dealing with the results of trauma, which cause musculoskeletal injury, or debilitating inflammatory arthropathies of the hands. And this is an example of a hip with bone-on-bone arthritis. And if we go back, and the other thing then is dealing with spinal cord trauma, which is both mechanically destabilizing and also obliterates the spinal canal and the neural elements. And so the one aspect is reconstructing things biomechanically and getting the bones to heal. And although as of right now we're not yet there, the ultimate hope someday is to be able to attenuate to some degree or perhaps even reverse neurologic injury, because the spinal cord and nerve roots run through this area which was obliterated by the fracture of the car accident. And this is again an MRI showing the trauma of the accident and the bone retropulsed into the spinal canal, obliterating the neural elements. And unfortunately, right now in this day and age, our main ability for these patients is to reconstruct the spinal column to provide them with a stable foundation on which to sit and do weight transfers from, say, wheelchair to chair. And it's fairly abysmal right now in terms of any neurologic regeneration, but the hope is someday to be able to do more than just mechanical support for this type of an injury. And this is the other extreme, would be a herniated disc or sciatica, which then presses on the neural elements. And the main thing we're treating with this is the pain, which we'll get into later, is multifactorial. It's both from the mechanical compression on the nerve root as well as the chemical insult that is caused by the inflammatory cascade of these tissues touching the neural elements in the spinal canal. And so currently our interventions are basically biomechanical and structural. If someone has a spinal cord trauma, we're able to decompress the neural elements, and then we reconstruct the column by basically interposing fusion cages and reconstructing the anterior and posterior columns of the spine. And so for that spinal cord trauma patient, we were able to remove all the bone from the spinal canal, the bone that was broken, rebuilt it with an expandable cage that's filled with bone graft, and then reconstruct the posterior column. So we still have a long way to go. And there's an example of someone with degenerative scoliosis for whom you then do, and left untreated, this curve will cause progressive curvature, which will impede respiratory function, cardiac function, and currently what we're able to do is reconstruct the curvature as best as we can and then stabilize it in situ with a long fusion construct. And then for osteoarthritis, we have a total hip replacement. And although right now I would call these treatments crude because we're basically acting at the end stage of the disease, and to be fair to orthopedics, I mean, total hip's probably the most successful operation in the history of mankind. I mean, total hip replacement, coronary artery bypass, and total knee replacement are the most successful operations in human history. So some of our treatments are good, but we don't want to rest on that. We want to do better. And the ultimate goal for arthritis, for instance, would be not to get to this point. So all these diseases have in common that they're end-stage musculoskeletal pathology. And all of our treatments have in common that we're basically operating once the damage has occurred. So we're pretty far downstream. And ideally, we want to get further upstream and intervene before these things become apparent, either through injury or in the office in physiology. And a lot of the disease, I'm going to now focus more towards the spine because that's what I'm probably most qualified to talk about, is basically through our lifestyles. You know, we started off more or less on all fours, and now we're back to a sitting and recumbent position over the past 100 years. And the issue is when we stand, it's probably a very nice position for our backs. Sitting actually causes the most mechanical stress on the intervertebral disc in your back. And so just by happenstance of our social evolution, we basically are now have assumed a predominant position in our lifestyles, which is the worst possible thing to do for your spinal column. And the impact of this is huge. Spinal disease and musculoskeletal disease is the leading cause of disability in terms of lost days from work, and it costs hundreds of billions of dollars annually, both in medical care costs as well as lost productivity of the economy. And an example of FDA has 510K approvals for studies for when someone files a 510K, they're going to bring to market in the future, they hope, a mechanical device to treat these diseases. And this just shows between 1990 and 2003, there's an average of 90 510K applications per year for technology to address the end stages of musculoskeletal pathology. None of these technologies are going to address upstream, which is really what we want to do. And you look at emerging technologies from the Millennium Research Group, all these technologies are for addressing end-stage spinal diseases. And this is a number of procedures forecast just over the next 2 years, look how much it's going to grow. And so what is the spinal column? Well, the spinal column basically acts primarily to transmit load through your body as you walk around. You have your spinal column on the bones, and then you have an intervertebral disc, which is a shock absorber. The intervertebral disc is composed of a nucleus pulposus, which is basically a hydrated hydrogel of proteoglycans analogous to the solid matrix of cartilage, and is surrounded by annulus fibrosus, which is predominantly collagen tissue, which acts as a tension band. So as you bear weight, you constrict, press down, water is dissipated through this matrix through frictional drag, and compressive energy is dissipated through that energy, and annulus fibrosus surrounds the nucleus pulposus and constrains its ability to swell outwards. And what we know with aging, all of us have this ubiquitous degeneration in our backs. This is sections through tissue and MRI, where you go from nice hydrated disc, and as we age, our disc collapses down and becomes degenerated. Now, we all have different stages of degeneration, but this is a fairly ubiquitous process. And that's significant because Scott Bowden in 1992, he looked at people who had MRIs of their back who had no pain whatsoever. So these are people who had MRIs for some various reason. And what he found was in asymptomatic people with no back pain, between 60 and 80, 93% of them has some evidence of degeneration in their back. And that's significant because, so if somebody walks into your emergency room, walks into your office and has this MRI and back pain, that doesn't mean this is causing the back pain. Because we already know if you're 80, 90% of people have this. And so it's not just enough to be able to look at the phenotype, as it were, the picture of a degenerated disc when someone has back pain and blame it on the disc. That could just be a irrelevant finding that's no more significant than the patient having gray hair or wrinkles on their face, because our collagen ages internally just the same as it ages externally. So what's emerging now is an idea that pain may be a distinct process from physiologic aging, because we now know once we're in our 80s, almost all of us have degenerated disc with no back pain. So why does the person who has debilitating pain that keeps them out of work, what is different about their degenerative process than people without pain? And we don't know the answer yet, but the hypothesis right now is that when you have an injury to the disc, a traumatic injury, be it a fracture of the end plate or a laceration, something happens in the body's attempt to repair that. And when the inflammatory cells go there, they secrete nerve growth factor, which causes the sinovertebral nerves that pathologically innervate the disc secrete chemical mediators, which then causes a massive inflammatory cascade and a pathologic degeneration of the disc, which is incredibly painful. And so there's some sort of difference between a pathologic degeneration and normal degeneration, which is different, and we don't yet know these relationships, but we need to figure them out. We want to really do a good job for these patients, a better understanding this pathologic chemical milieu that occurs in that setting, and then intervene in it early before your disc collapses and is gone, and you have two vertebral bodies sitting on one another, because it's much harder to reconstruct that after the fact. So what data supports all this? Well, some work was done in Jefferson and Philadelphia looked at gene expression in traumatic disc injuries and found significant upregulation in an animal model after a traumatic laceration of MMPs, fibronectin, and interleukin-1 relative to control. So what about a human model? Well, we took people who went to the operating room for surgery with a degenerated disc and compared their discs to people who had their discs removed for another reason. Say somebody who had a car accident, spine trauma, had to have the disc removed for a fusion procedure, scoliosis. And what we found was, even though these discs were both the same MRI grade degeneration, they had very different cytokine profiles. So there's something different in the chemical milieu of these patients for painful versus non-painful discs that are degenerated. And then an animal model that I worked with some collaborators at in Maryland on for a null mouse who, unfortunately, the patent lawyer sort of beat me up before I came, so I can't say what the knockout is, but this is the wild type mouse. You knock out one transcription factor, and this is what you do to the spine. You get a degenerated disc with a scoliosis phenotype, and the micro-CT looked at all the bone, and the histology of these discs look just like an old person's degenerated disc, just by knocking out one transcription factor. So there's much more going on here than just the end-stage phenotype that we're going to reconstruct surgically, and the ability to intervene upstream and modulate these things could have a tremendous effect on these people. But it's not just enough to modulate it, you also need to be able to diagnose it, because by the time you see the x-ray of the degeneration, or then your office or the disc space collapse, now you're not only modulating, you also have to rebuild tissue from scratch, and that's much harder to do. So we need to identify these people early and intervene early and modulate it to prevent this from happening, and there's every reason to believe that's possible with the emerging data that we're learning from this. And so the net effect, so far what we think is small perturbations have a profound effect on the phenotype of the disc, and we now know there's probably corollaries to genetic predispositions, because some people say, oh, we have bad backs in our family, or some people's families are more prone to osteoarthritis. So what are the treatment options? Well, right now, in terms of what we're doing in orthopedics for joints, spine, or everything in the bone, there's a lot of excitement about cell therapies and protein therapies, and there's a big debate for what should we do. At some point, you're going to intervene with either protein that you inject, cells that you inject, or cells that you inject that are transfected to make protein, i.e. Stem cells that are transfected with a gene for BMP. Wherever you're going to intervene, as a growing recognition, you better intervene here, because the further you go, the more you start to destroy the actual tissue itself, and even if you stop the process, you're left with a suboptimal tissue structure. So we need to do early diagnosis and early intervention. Now, my personal bias would say the nucleus pulposus is probably, in my opinion, the most biologically inhospitable environment in the human body. It has no blood flow. All the nutrient transport is through diffusion mediated. It has a lower pH than most other parts of the body. And so basically, a nucleus pulposus cell is like this little guy in the spacesuit sitting on the moon. And these cells are specially adapted to survive in that environment. So what that means, in my view, is probably protein therapies are the way to go, because injecting stem cells or external cells into this environment is probably not going to be the first tissue in the history of humankind that we have stem cell therapy working well. It's really a real challenge. I'm not saying it's not possible, but probably protein therapies are going to be where we have the most success early on. And articular cartilage, in some ways, is similar for other reasons because of the hydrostatic pressures in there. So what do we have to support this? Well, I'm going to go through this part quickly to get to the nanotech stuff at the end, because everybody wants to hear. Well, one in vivo model I worked on was with a rabbit model for disc injury, where you then did needle punctures, injure the disc, and then did stem cell transplantations after injury. And so this was sort of the surgeries. And one key thing about this is if you don't have a good delivery mechanism, the only way to get the cells into the disc is to inject them. Well, this is going to show, this is a needle injection of a disc. And this isn't part of the talk, but this is a biomarker that we made with imaging for early diagnosis. This is the normal disc, and this is a disc 4 weeks after we stabbed it with a needle, which you'd have to do to inject the stem cell treatments. And we're getting very good now at pre-symptomatically having very high-resolution biomarkers and imaging for structural degeneration. So we can diagnose the disease early, but we don't yet have a way to intervene and treat it. And this is a whole separate topic of biomarkers. And this is an example just like the biomarker. This is what a conventional MRI would show for the disc with response to stab injury. And this is what's emerging now with our ability with biomarkers. We have much better resolution. These color-coded maps correspond to T2 relaxation time, so we can actually visualize the tissue structure of the disc. So the technology is here now to non-invasively assess the structural integrity pre-degeneration, or to assess the integrity as it responds to a treatment therapy, but we don't yet have a treatment. So our aim is to get upstream, diagnose it early, intervene, and do something hopefully better than what we're doing now, which is end-stage reconstructions of degenerated joints. Because it's a lot easier to intervene up here than to start down here and try to climb your way up. And so right now we're collaborating with Enyo and Dr. Ferrari, and then at the Methodist Hospital is Dr. Weiner, myself, and Dr. Liu. And so for early diagnosis, Enyo's group has done a lot of work that he already went over with you guys with his protein chips. Now, he didn't spend a lot of time touting it. What I heard him talk, the first thing I think about is you can use these chips for diagnosis. Because we're already established there's a huge cellular cascade going on here, or if we can we haven't even characterized it yet. So first we need to get everybody and just figure out what exactly is going on in the proteomics of these patients, normal patients or diseased patients. Once you figure that out, then we can think about how best to intervene. And we know this is significant because from our animal models and the human data I showed you, we know there's differences between the chemical milieux of these different people. And so at some point, if Enyo stands up and waves at me, it means I got in trouble, but I think I took out most of the slides that they made me take out before I came, but just in case, he's watching me closely. So with the silica chips, he told you about all of his ideas for them, but when I hear them from my perspective, what I want to do, these chips are basically molecular sieves. They're perfect for proteomics. Because what we can do now is, if we take the tissue out, or we take out fluid from the joint, we can drop them onto his chips and do proteomics, which is the equivalent. I mean, first we had 2D gel electrophoresis, then mass spectroscopy, but what these chips can do in theory with the nanotechnology of protein sorting is provide high-resolution maps of what exactly is going on in this tissue. And that's what we need to do to get our handles around these diseases to intervene and do treatments for them. So that's everything that he's talked about. He has so many wonderful discoveries. This is the only thing that sticks in my mind. He's told me so much. This is all I know. This one slide. And the reason for this is biomarkers are key for all these diseases down the road. And if right now, our option for biomarkers is we go into the operating room, get the fluid out, have to put protease inhibitors on the fluid. Then that has to go either for an ELISA assay, a specific ELISA assay where you already have to say ahead of time what you're looking for, and they're very costly. If you don't do an ELISA assay, there's other options, mass spectrometer and other things, but all these things are unwieldy, and they really make it difficult to translate the technology into the clinical environment, because you're in the operating room, you're not going to get people who are going to take the time to collect those samples, put protease inhibitors into them. It's just too unwieldy. But if you have a little chip you can drop the fluid onto, and it's stabilized, and you do the proteomics, you're going to rapidly advance our ability to treat these diseases. First off, to characterize the diseases so we can even figure out what's the best way to treat them. And as an example, and I'm not doing justice to what Enyo and his group have done, but I'm just what I think about it, is these chips, because the pores are so small, the enzymes that degrade the proteins can't get into them. So these proteins are stable in these chips at room temperature for, I think, as long as he's tested them. So in the operating room, I can take some cerebrospinal fluid out, drop it on the chip, put it in an envelope or my back pocket or anywhere, and then they can analyze these down the road and get high-resolution proteomics, which is, so far from what I understand, better than, or at least equivalent to what we know with mass spectroscopy, without half of the rigmarole you have to do to maintain those samples. That's the kind of technology that we need to really translate these things into the clinical environment and affect quality of care for the patients. And the other option then is spinal cord injury, and I'll go quickly because I'm running out of time, but the holy grail, or one of them I think really for what we do in terms of spinal cord trauma, is to do something for these patients that have these devastating neurologic injuries. And right now, this is the American Spinal Cord Injury Center's classification chart. When somebody comes in the trauma bay, we classify their spinal cord injury based on nerve root level of function. And basically, this is a nerve root level is going from here to going to here. If you can preserve one level of function, you dramatically change that patient's life forever. If you go from C4 to C5, you have someone who's on a ventilator to someone who's not on a ventilator. You go from C5 to C6, you can work a wheelchair. C6 to C7, you can extend your arm. You can push yourself out of a chair. You can transfer from bed to chair to other areas. You can walk with crutches. So just preserving a little bit of an area, you'll change someone's life forever. So how do you do that? Well, the issue with spinal cord trauma is not just the blow to the spinal cord. After you bang the spinal cord, you get a tremendous secondary cascade of inflammatory markers and degeneration, which is called the secondary injury. So there's a lot of talk in the lay press about giving people with spinal cord trauma steroids. Well, that's just a big brute force attack to try to knock down all those cytokines. Some of those cytokines are probably important, so you don't want to get rid of all of them. And what's even more important is the temporal timing of when those things are released. And so the first step is to characterize it. It has not yet been well characterized, the distribution of these cytokines, the temporal distribution, which ones are good, which ones are bad, and how does that correlate with spinal cord injury. And then the next step is the glial scar. After you have this massive secondary injury, you then get a glial scar that forms, and that glial scar contains proteoglycans which inhibit the ability of axons to grow and regenerate. And Regeneron's got an oligodendrocyte stem cell trial. All these therapies are aimed at modulating the glial scar. So you need A, a way to characterize what's going on, and B, a way to deliver the treatment. And this is just a schematic diagram of, so far at least, what we think is going on with the secondary injury cascade. And this is probably 10 years from now, we'll look back at this and laugh, because this has nothing on it for graphs of time. This doesn't all happen at once. These are things that happen, it's intricately balanced, and if you can modulate this cascade, you modulate the secondary injury. If you modulate the secondary injury, you restore neurologic levels. There is well-reported in the literature for cervical spinal cords, there's a high incidence of people have an injury at one level, and they will then ascend and lose additional levels in the time post-injury because of the secondary cascade. I saw someone go from C7 to C2. They went from arms to not able to do anything below their chin just from secondary injury. If you can modulate that, you change people's lives. So now the nanotech. So the nanopore silicone enclosures for drug delivery is one thing we're actually working on doing right now. And this is important for fracture healing, fusion, delivery of therapies, and if you want to relate into a treatment of osteoporosis. And so spinal fusion, when we fuse a spine, the whole goal is to hold it still while the bone heals. Now, for one level, that's relatively straightforward, but when you're doing a complex fusion, if this doesn't heal properly, you have a complete disaster on your hands. So anything you can do with hydroxyapatite carriers that can modulate or deliver biologics to enhance a fusion in a high-risk patient is a tremendous benefit for that patient, because these surgeries are high-risk surgeries for the surgery to fail and not to heal, and a non-union is a complete disaster in this setting. So this is something that has an immediate and direct applicability for biologics. Right now in the United States, BMP2 infused Medtronics, it's a $2 million US per day are spent on this product just for spinal fusions. And that's one product. There's a tremendous clinical need to deliver these products. The BMP2 doesn't even have a good carrier. It's in a collagen sponge. It's FDA approved to use anteriorly intervertebral. If you can get a hydroxyapatite carrier or rigid, it tremendously changes the way it can be used. The other issue is antibiotic delivery. In the setting of all these things, the other big nightmare for us is infections. Postoperative infections are just a total disaster, and it's a major, major issue for reconstructive orthopedics. Right now, we have this technology we're working on. We don't. Enyo has the technology, which he's letting us use, to deliver antibiotics in a targeted way with these nanoparticles. And that's tremendously important, because the ultimate goal would be possibly to then cap these silicon particles to implants. And then you can develop implants where you can perhaps turn on or turn off antibiotic delivery, turn on or turn off osteointegrative factors, and revolutionize the way that we treat these diseases. And this, unfortunately, I'm out of time, so I don't have time to go over it, but right now we're able to do with these silicone capping is have controlled release of these antibiotics over time in a very efficacious way that can be modulated on the way that these particles are capped. And that then allows eventually, through the tunability of these, to release antibiotics, but not just antibiotics, any kind of protein. So bone morphogenic proteins, perhaps antibodies which could bind to particular cytokines and modulate injury cascade. So if you have the ability to put a deposit of these particles in an area, say spinal cord trauma, and then modulate the temporal release of those particles to modulate a characterized secondary injury cascade, you can revolutionize the treatment of spinal cord trauma. And I think I'm out of time, so I'll just go through these things quickly. And I think in summary, there's been a lot of work. If you're a mouse, you're really living in a wonderful world, because we've cured a lot of diseases in mice. We can cut mice's spinal cords in half and make them walk again. But, and Daryl Jackson made this quote, we're doing great things for mice, but none of these things have been done in humans yet. That hasn't been translated yet. And I think the real goal is going to be to move out of the mouse and move into clinical trials and translational research. And I think the technology that we've been talking about these past few days really show a lot of promise, and particularly musculoskeletal disease. I think that leap could happen a lot sooner than some people realize. Thank you.
So in one of your early slides, you said that maybe there's too much NGF around, and this is causing chronic pain. And could you simply just deliver an anti-NGF, perhaps for a sustained period of time? Like, is that hypothesis? Have you tested that hypothesis?
It's a theory. It hasn't been well shown. It was a paper by, I believe, Penn et al. In Spine, I think 2006, which was the idea is, when the disc is injured, such as an annular tear or fracture, the body tries to repair it. But because the disc has such poor blood flow, the reparative process doesn't work. So you get a vascularized ingrowth of granulation tissue, and then it doesn't heal completely. And then wherever blood goes, usually then the nerves follow, in general, and specifically the mast cells secrete nerve growth factor, and you get this abnormal innervation of the disc. There's thoughts about that. One idea would be to what degree is pain relief from vertebroplasties or fusions from ablating that nerve, and there is people thinking about it as a way to target that nerve and ablate it. It's still controversial that is truly the pain generator, and the other issue is once these discs get innervated and sensitized, there are so many nerves wrapped around all the joints. So the answer is yes, people are working on it, but by no means is it a solved problem.
So coming from the oncology world, I mean, one of the things that my colleagues used to say was that everything looks good in mice, right? Which is true because they're inbred, whereas we're outbred. And so the component that I think is missing for translation, at least in part, is specific proteomic information and then some understanding on a modeling level of what the particular proteomic information actually indicates and what an appropriate intervention would be. So,
yeah, and that was so exciting me hearing all these talks was almost everything I heard today lent itself directly towards that, either protein characterization or targeted delivery or targeted delivery with the ability to modify it temporally. And that doesn't exist right now, and I think that could really revolutionize the way we do these diseases once we understand better the characteristics of the milieu, the proteomics of the disease.
You wonder, in a sense, why people continue to use inbred mice and not, wild mice, essentially, and ones that have polymorphisms and can actually are more similar to the human condition. Why is that? Do you have any experience?
I really don't. I have no idea.
Any further? Well, thank you. That was,
Thank you.
Very excellent talk. And